And then the last company presentation is Healthify.
How's everyone doing? Last presentation of the day. Who's excited? Hopefully everyone got some coffee on the previous break. If anyone wants to stretch during this presentation, I did a few minutes ago. Feel free, I won't mind. Name's Monik. I'm the CEO and co-founder at Healthify. I'm joined by my two colleagues, Cesar and Olivia. And I'm really excited to be here. Thanks again to the Adaptation team for setting up this event. It's been phenomenal. From 2008 to 2013, I was a community health worker in East Baltimore. I was at a pediatric clinic, a community psychiatry clinic, a small men and family shelter, working with high needs Medicaid families. And what I saw day in and day out was that the biggest needs families had were social needs and not clinical needs. We know this. Food, housing, childcare, employment, access, transportation, those were the needs that mattered. Those are the needs that dramatically impacted cost and dramatically impacted outcomes. And I'm preaching to the choir, but I want to just, again, level set on the delta here. Where I worked in East Baltimore, zip code 21218, 2 zip codes to the right, the life expectancy difference was 20 years. So let that sit with everyone. That's absurd. And that's why we started Healthify. We said, if we're serious about value, if we're serious about bending the cost curve, we have to be serious about how we scale systematic solutions to address the social determinants of health, because it's really the elephant in the room in healthcare. But more tactically, what do we do on the ground? And we've been in this space for 6 years working with a variety of national health plans, risk-bearing providers in the public sector. And it's a big concept, social determinants. It's hard to know where to start. So we built this framework called the social needs funnel that talks about the specific pain points we see health plans and state partners face. I'm going to walk through each section. I'm going to talk about specifics of what we actually do to help a health plan address each pain point they experience. So at the top of this funnel, there's this pain point of identifying needs at scale. If you're managing a large membership, it's hard to know who is actually food insecure and what is the severity of their food insecurity. Screening doesn't always take place. Clinical risk scoring doesn't capture these needs effectively. And the inability of identifying needs at scale makes it really difficult to allocate the right resources, prioritize the right interventions, or build the right network to address these needs long term. We do 2 major things here. Number 1, we roll out a platform to help with dynamic social needs screening that matches folks to the best services based on the needs that are identified. And this can be deployed member-facing, staff-facing, or to a caregiver. And we use a lot of the common assessments that are out there, like PREPARE and the AHC model. And we actually supported CMMI in building part of the Accountable Health Communities model, which is a large model looking at social need intervention tied to ED utilization. I'm happy to talk more about that. That's one way of doing it. And it's a really granular way, social needs screening. The second way we tackle this pain point is predictive analytics. We can take high-level demographic data from a health plan and have a couple of data partnerships and have built models around unstable housing, food insecurity, social isolation, to really think about what is the cohort of members to build an intervention around and what would be the potential impactable cost when you identify needs in that way. And there are pros and cons to either approach that I'm happy to get into. That's step 1. Next major pain point we see a lot of people struggle with is once you identify the need, what are the services that can help? Federal state benefit programs, hundreds of thousands of community-based agencies doing great work on the ground. The best way to visualize this example, and I use this example often, it sounds pithy, but it makes it resonant. I can get on my phone right now, which I'm going to do probably after this meeting, and look for what's the best pizza in a pizza place in a 2-mile radius. Yet, if I'm working, do people know what it is? I'd love recommendation, but don't use it now. But if I'm working with a family who needs childcare, or a family is looking for childcare, good luck. The information is out of date, tough to share, not validated, paper-based. There's a huge access to information problem. So here what we do is we deploy a search platform, a quick and easy way to find community-based services you can trust. We build a database, we validate the data, and again can deploy it in a couple of ways. Staff-facing, so you can actually understand the engagement of your staff with what needs are popping up via search, a community portal that can be white-labeled, and a member-facing portal which can be integrated to a member application. And these 2 top-of-the-funnel pain points, identifying needs and finding services, are deeply important, but not really our core focus and not really where we think the biggest outcomes are produced. Oh, whoops, hit the button by mistake. The next major pain point is coordination of service delivery. To visualize this, let's say an Olivia and Cesar were working with me and identified Monica is a diabetic senior who needs mobile food distribution. They identified the need, and they found Meals on Wheels in the community. Now they make a referral to Meals on Wheels. It's usually where the conversation ends. Meals on Wheels has no idea I'm coming. If I show up to Meals on Wheels can't make an appropriate referral to a transportation vendor if an emergent transportation need came up. The health plan they're both employed by have no visibility into knowing what the outcomes were when the service was actually delivered to me. And Meals on Wheels is not incentivized to support that referral either. So there's deep fragmentation of service delivery. There's no true accountability, no true transparency. We do two major things here. Number one, we deploy a team to build curated networks, contractually bound networks of community-based providers around specific interventions. And we handle everything from identifying the right community partners, evaluating the community partners, signing the appropriate SLA documentation and community partner agreements. And number two, we deploy the platform for them to coordinate care in a network. So care manager A can make referral to community partner B, who can make referral to community partner C, and can see how those needs are changing over time. Because just if you make a food referral and someone is food insecure does not mean they're not food insecure anymore. You have to understand how these needs are evolving over time and sharing that information in an appropriate way with a health plan and community-based partner. And it all comes back down to outcomes. So we have an analytics platform that reports on each chain of this funnel. So you can now build a case to say, I have 20% of my population that's acutely food insecure. I have a network of food intervention providers that I'm coordinating referrals with. I know what interventions are being successful, and I can tie that back to metrics that are important to me. And that's what we're about. We build infrastructure that really integrates the social determinants of health into the era of value-based care. A little bit about us. We've been very blessed over the past few years. We support 10 million lives across the country. We're nationwide. We're in all 50 states. Here in Arizona, we work with great partners with a large deployment of Dignity Health and United Healthcare, and a lot of great large community partners like the Goodwill and Helping Families. And we've trained over 40,000 staff in multiple settings. So what's unique about us is we work with payers, providers, the public sector, community-based partners, and we've learned a lot about how do you actually build a workflow for community health workers, a care manager, a social worker, even a PCP to do this work, because their workflows are very different. And if you don't keep the workflow top of mind, these implementations don't work out too well. Now let's talk more specifics about technology and services. And I think Andre mentioned this at the top. Technology is not a magic bullet, and we have the scar tissue to prove it. For us, we look at if you don't think methodically around sustainability, incentives with community partners, long-term engagement, integration with care management and health records, you're not going to get very far. So we think of our work as technology and services really married together. So on the technology side, again, to recap, we provide this social determinants platform that has a couple of key components. A dynamic and robust social determinants screening tool that can be customized by population and matches people to services. We have an algorithm that says if someone is food insecure, we're going to match them to the best service in the area to automate that portion of the workflow. The ability to search for services at scale. Again, we're nationwide. We have over 400,000 services in our database. We work with folks like 211 and United Way in a lot of communities as well, and happy to talk at length there. And then most deeply, we have a coordination platform to coordinate referrals in a network specifically around the needs that are identified. So now you can finally track in a community in a robust and transparent way what referrals and interventions are working, what community partners are successful, and how do you potentially expand the network and optimize the network long term. On the integration front, we're integrated with all the usual suspects. Here in Arizona, we're actually already integrated with the HIE Health Current, which we're really excited about. And there are a lot of ways we can think about the integration depending on if we want to integrate screening information or referral information. And the reporting side, we can report on every component here, and I'll talk about reporting in a second. Now on services, so this is the heart of the matter, because the end state goal with the integration of social services into healthcare is not only optimizing identification, finding the service, but really coordination with a capable and contractually bound network of community partners. We can drive real reimbursement frameworks down the road. And we help with this very specifically. We deploy what we call our network advisory team that helps in 3 core buckets, just so folks visualize tactically what we can do on the ground. Network strategy. What are the interventions we're going to build based on impactable cost of the plan? Network build, owning the contractual piece of actually contracting with these community partners, the privacy component that was discussed earlier, the SLA and metrics development to make sure that community partners have an understanding of how they're going to respond in this network with a health plan that has obligations and metrics they need to be held accountable to. And finally, network management. How are we managing the SLA structure with these community partners that we're building interventions around? And we help with all of that. What I want to spend the rest of the time doing here is talking about what are the steps each of the health plans in this room can take to bring this to reality. And I'm going to walk through some of the initial steps we help plans undergo when building a real program on social determinants. And it starts with these three core buckets. What's your strategy at the enterprise level? What are the success metrics? What are the measures you're looking at to drive value? What are the programs you're going to be built around? Are you going to primarily deploy in your care management arm, or are you going to have a community health worker arm, or otherwise, and population mix? And then what is the infrastructure? What's the underlying people, governance, SLAs, community partner relationships, and data sharing requirements that are specific to your plan and your state that make the most sense for this network to work? Starts, number one, quantifying the needs in the community. So here's based on 6 months of data in our partners in Arizona. And very similar, it's great to see some of the information we have here matches a lot of the other information we have with other folks. We have screening information here and search information. So social needs screening in Arizona and what people are searching for. And you can see there's no clear surprise here. Food and housing are the top two categories from a screening identified workflow that is staff assisted and a search workflow as well. And it matches up to a lot of the state data. 68% of eligible Arizonans participate in SNAP, 1 in 6 Arizonans experience food insecurity, and we're seeing that reflected in a clinical workflow and also search data. That's step one, to understand the need. Step two is, let's look at where do we deploy? You can't boil the ocean. You have to start and drive success in specific communities first. So some geographic insights. We look at medication termination density. And over here is really interesting. We looked at what is the housing search volume? So where people are searching for housing services, how does that compare to what housing resources are actually available to understand what the delta is? Because now you can answer the question, I know there's a tremendous housing need or a food need in this zip code down to the street code level, street address level. How does that compare to what services are actually available? You can build that case to start narrowing a program scope. Next, we use predictive modeling. Here's an example of a predictive model on unstable housing, where we took a couple of different data attributes like property records and consumer information and worked with 130,000 Medicaid population in MA and identified that about 89 folks of their membership they had no idea were currently residing in a shelter. 225 were identified as critical housing risks. And we compared the total medical expenditure of those groups adjusted for age, gender, and their clinical risk score. We saw a pretty tremendous difference in PMPM. And the impactable cost was large. So now we have a good understanding. If we're going to put the investment to build a network that is aligned around a specific intervention, we have clear visibility on what we're doing. And if we look at Arizona, we know the housing crisis in Arizona is quite large. And if we looked at client by client, the variation of the delta is around 10%. But if we look at a similar value we saw in Massachusetts, the impactable cost of homelessness in Arizona is tremendous. This is no new news here. So what does the network look like? Now we're ready. We have an understanding of the locale, the needs, the impactable cost, the intervention design. Here's what a network looks like. So we deploy Healthify in multiple partners. And one example you can see here is member presents at either provider or a care manager employed by a health plan. A screening is done, or it's surfaced to them that this member was previously identified as high risk. They can now initiate a referral to a curated in-network group of community-based providers across all these domains. At the community-based provider, they're also on Healthify. They've been onboarded and trained. And they can go into Healthify and respond electronically and know if the fulfillment of the service is actually delivered. And there are multiple states and customization there that I won't get into. And they themselves can make another referral to another network provider around a specific need. And then all of that is shared globally to those community partners, to the agency that might be the hub account, the health plan, or the provider, and we can also share that up to the state too. And finally, we can assess the performance and the impact of these predetermined metrics in that network. And once we define the intervention and network design, now we're ready to go live and deploy the technology, the network itself. And you actually see Olivia's face here. She's standing right next to me. We have a dedicated team to help you with this process, from account management to product support to network managers, to help you build, operationalize, and maintain a network of community partners once we've done the heavy lifting of what we're trying to accomplish together. When we think about growing the network, we take a really crawl, walk, run approach. Number one, year zero, is really building out the efficacy around a focused use case based on the data we're gleaning. We scale that network across multiple use cases, and we have initial focused ROI around near-term utilization reduction and then looking at total impactable cost long-term. And we work with our health plan partners to figure out what are the key metrics they want to look at with a line of business they want to start doing this work with, get some early wins, and then scale from there. Oh, slide got a little formatted incorrectly. Here's a quick case study of a client of ours where we deployed Healthify to operationalize their screening workflow. This is with the Accountable Health Communities model. Conducted referrals across a network of community partners and saw that if the contractual network with community partners did not exist, The difference of it existing around specific interventions increased the completion of referral. I'm defining completion meaning referral was made to a community partner. That community partner has said that the service has been rendered to the individual, increased by 11x in almost every single domain we looked at, from food, housing, childcare, employment, and financial assistance. So the results are very clearly there when we look at a raw metric of completion when a service is rendered for a family. What we're interested about in the future, I got 1 minute left, and I'll focus on one here, which is, I think, the most important, which is why I'm excited about everyone in this room being in the room together, is reimbursement. We feel the long-term sustainability of this space is going to be dependent upon how we think long-term about the sustainability engine and the payment engine for community-based providers. And we're supporting a lot of emerging models. There's VBP arrangements in New York between health plans and community-based partners. There's emerging work in the MA space for supplemental benefit redesign for home-delivered meals. What we have an opportunity to do together here in Arizona is understand what are the appropriate rates and how do we actually scale a potential program for payments around social services that are really driving real outcomes, and we're really excited about that. And I'll close in terms of why Healthify. There are 3 core buckets we think about in our work. We're outcome-driven. We're more than just a technology company. We care deeply about our application, our integrations, our services to really drive towards real outcomes. We're comprehensive. We're not a point solution. We can own the entire value chain from identification of need all the way down to coordination of service delivery with a network of community partners and help you build and maintain that network. And we have proven scale. We're high-trust compliant, long, 2.5-year-long process. We have national scope. We've adopted the open referral standards. We'll actually match our taxonomy to ICD-10 and Z codes already, and we're deeply modular and interoperable. And with that, I will close off. How did I do on time?
Great.
Perfect.